Welcome to the Our Forever Smiles podcast, a podcast created to support mothers of children who were born with clefts and those who love them. I'm your host, Laura Arroyo. Hello, and welcome back to the Our Forever Smiles Cleft Mom Diaries and Support podcast. I am Laura Arroyo. Before we jump into this episode, I would like to invite you to join this community to hear conversations with other cleft moms and advocates that will help you feel supported along your journey. There's a Facebook group I would love for you all to join. Just click on the link in the episode show notes, and it's incredible to see us all to come together, and we're just getting started. We have so much in store for you this year, so thank you for joining the community. As a note, we are not medical doctors. We do not intend for you to use information that we share here as medical advice, although we do have a doctor on the podcast today. She is not your doctor, so just make sure that you check in with your own doctors. We're parents and advocates, and we just love our children, and we want to share our own personal experiences. Today we have Dr. Funke Afolabi-Brown, and she is a sleep medicine physician and the founder of the Restful Sleep Place, and she helps families improve their sleep to thrive and reach their fullest potential. Welcome, Dr. Brown.
Thank you so much for having me.
I'm so excited to have you on because I actually didn't even realize that sleep apnea, sleep disorders, or just like the involvement of sleep along the cleft journey, like how it's so connected. I didn't even realize that until I actually went into like the moms groups, and I was like, wow, so many people are asking questions about sleep after repair and before repair. And I've just seen a lot of things. So, thank you for joining us today. I guess we'll start all the way from the beginning. Like, what made you start practicing in sleep, and what's built your interest in this particularly?
I'm a pediatrician who was really interested in pulmonary medicine, so breathing, asthma, all of that. And then I realized that there were so many people with breathing issues who also had sleep issues. So that really fueled my interest to pursue a training in sleep medicine. And I just fell in love with it, not just from a sleep apnea standpoint, but behavioral sleep stuff, circadian rhythm, all these, teenagers that can't sleep or won't sleep, and the toddlers that need help. And so there's so many levels to it. So initially it was really around the sleep apnea that got me involved. But then I now realize there are many, many dimensions to sleep and sleep health. And so now that's really the main thing I do now.
Yeah. And so do you still focus primarily in pediatric sleep? Is that like your realm of specialty?
That's my niche. So very, very few people in the world actually do pediatric specific sleep. So that's definitely an area of focus of mine. But I also see adults. Usually we'll say, I see the dyad. When the mom comes, the mom's not sleeping and they bring their child who's not sleeping. So I'm the doctor for the mom as well as for the child. So do have that specific niche in pediatric sleep as well.
Hi, I am so sorry to interrupt the show, but I just want to tell you about today's sponsor. Today's show sponsor is Sienna Dawn Media Integrated Marketing Agency. Sienna Dawn Media is more than just a marketing agency. They are your partners in progress. Their mission is simple: to alleviate marketing bandwidth, allowing creative business owners to focus on what they set out to do: create. Sienna Dawn Media empowers creatives to thrive without the burden of managing their own social media and marketing campaigns. Visit siennadawnmedia.com. That's so interesting because now my mind goes to so many different things. I feel like, there's this new trend in like sleep training, right? When we, as the moms get tired and we are trying to figure out solutions to help our babies go to sleep, right? Or to have restful nights as well as ourselves. Like, what is your opinion on all of the sleep training stuff that we are going through?
Yeah, I mean, so much controversy. It's so sad, right? I would say, I think the definition is what gets people stuck. Because most people think sleep training, and the first thing is, oh my God, cry it out. I can never do that. And I could never do that either. You're telling me just leave my kid in the room to cry till morning. That sounds harsh. But that's one type of sleep training. Sleep training is all about teaching your child skills that will promote independent sleep. so that they have sleep confidence and you and everybody else can sleep at home. That's all it is. And there's so many things you could do to accomplish that. It may just have to do with their routines. All of a sudden, maybe they didn't have a routine, and that's why their sleep is so chaotic. You put in a routine, guess what? That's a version of sleep training. It may be cry it out. I've had parents who come in and they said, well, I almost got into an accident because I was so sleep deprived because of my child's sleep. Well, we're going to really do some drastic measures because we need you to be alive. So it all depends on where you are on the journey. It depends on what your values and your philosophies are as a parent, but with the ultimate goal of how do I get my child to learn how to sleep independently, because it's a life skill. You won't say, oh, I don't want them to be uncomfortable when they're swimming, so I'm not going to teach them how to swim. Or I don't want them to be uncomfortable when I try to put them on a seat belt, so I'm not going to have them sit in a car seat with a seatbelt. That's not what you'll do. You know what's best for your child. And knowing what we know about the consequences of poor sleep on the child's mental health, the child's learning and development, the child's immune system, it kind of becomes the thing that we do want to make sure that we're empowering our kids with the right tools they need to thrive. And really, when you go in with that mindset and know that sleep training does not mean cry it out, I think it becomes less of an issue.
Yeah. What is your like preferred method? Do you find that like one method works over another?
Well, the research shows that all the methods work. Some just take longer than the others. So there are thousands. In fact, there's a study they call a meta-analysis, which is like a combination of multiple studies where they've actually looked at the cry it out. They've looked at all the different methods, and they found out that they're all effective. They find out that they improve maternal health and maternal and parental well-being. They improve, the child's development, and there's really no issues with, oh, long term you're scarring them emotionally. None of the studies showed that. But they did show that the shortest one, that's almost like pulling the plug, is the cried out. It is the most effective. But it doesn't matter. The other type is what we call like the chair method or the check-in method. They all work. They all work. So it depends on where. Again, this is why like my practice is super personalized. It's not like, oh, you must do this. It's really about what can you handle? What can you tolerate? What are your values? What's the most important thing for you right now? And then we could sort of tailor an intervention that suits you. I think there are a few things to consider: the consistency, because if you say, okay, I'm gonna go in and do maybe the check-in method where you're going in and checking in from time to time, and then after doing it for 2 nights you just abandon it, that's worse. I think it's actually better to just do cry it out than do a method and be wishy-washy about it. You know what I mean? So the answer is it depends.
Yeah, I was too much of a wuss, I guess, to do the cry it out. I couldn't take it. But I did do a method. My daughter's always been great with sleep. She picks up things very quickly. We did more of like a check-in method, like I was able to. But she has never been. Wow, this is like bringing up so many things that I kind of felt like I didn't even know. I went into this like, I really hope I have enough conversation about this. But now I have so much conversation because I want to talk about so many things. But so I actually had to transfer her over from her bassinet pretty quickly, like sooner than what, the recommended. I think it's 6 months in the room with the parents, right?
Yeah, yeah. I mean, bassinet usually once they start to roll over, so by 3, 4 months, and then if they're big enough, yeah.
Yeah, she was out of my room by like 3 months, which I think for some people is kind of like, that's really early, Laura, because she was in her own room because she started rolling over in her bassinet. And so it was like, well, you need your own space. And just she moves a lot and she's still like that. She tussles a lot at night, but she sleeps very well by herself and she likes sleeping by herself. She's never been the child that wants to be held. I want her to be, but she doesn't like it. And she likes to be free and like able to move around and all of that. So anyway, it's just making me think about all of these things. But she has always been a great sleeper, but I have had colleagues that say, my child just won't sleep at night. Is there like something that is like causing that? I know it's probably potentially many things, but what do you see frequently that might be a reason that a child isn't sleeping?
Yeah, no, there's so many reasons. So I think to make it easy, because when families come to see me, it's the same. It's like there's so much chaos. They don't even know where it started from and where they're going, right? So we look at it from three. I usually will say three categories. The first is more of the medical bucket. And I think that's the most important. Do you have a child who is waking up in the middle of the night because they're not breathing well? If they have sleep apnea, if they have reflux, if they have asthma, eczema, allergies, there's so many things that could be going on. So that's the medical bucket. And I feel like that's something you have to address before you now just assume it's all behavioral. And so the second is more of like behavioral issues. Do they have a hard time self-soothing? Even for a 5-year old, a 6-year old, sometimes that might be the issue because they don't know how to put themselves back to sleep. They're so used to a parent being there that when they wake up in the middle of the night and the parent is gone, they have no idea how to connect those sleep cycles. So that's another really big one. And then the third bucket is what I call more of the 24-hour factors. So if you have a child who has a neurodiverse condition, autism, ADHD, some dyslexia, anything of that sort, or anxiety, that might make them wake up and then their mind starts to spiral and they really have a hard time settling down. So those three buckets, the behavior one, sometimes it may be related to limit setting where the child is like, I want another cup of water, or I want to use the bathroom again, multiple requests. So there are many things. So when you kind of break it into those three, it then helps us kind of tailor an intervention that's specific to your specific situation. So it doesn't feel like you're throwing spaghetti at the wall.
Yeah, that makes a lot of sense. And just thinking about like my own daughter and like how I had to kind of separate in order for us to both have restful sleep. Sometimes that doesn't work for other babies or toddlers. And so what is your opinion and another controversial thing on co-sleeping?
I side with the American Academy of Pediatrics. I mean, there's some, to be honest, I feel like sometimes it feels a bit extreme, but as a pulmonologist, I have had children come in with near death experience from suffocation, or unfortunately, I don't get to see them because they passed away from SIDS. From either they were held or there was co-sleeping and then they suffocated. If you think about it, most of the people that end up needing to feeling like there's a need to co-sleep are parents or moms who are tired. When you're at a point where you are so exhausted and sleep deprived, your body goes into really deep sleep, which makes it very hard for you to arouse if something is happening. In fact, some people just don't know. They're so dead asleep and dead to the world because they've been so sleep deprived. They're not aware that something bad is happening. So I would say personally, from someone who has been on the front line and seen those kids who now become pretty much brain dead because oxygen supply was cut off before somebody discovered it. I side with the American Academy of Pediatrics, which is that you should not co-sleep, at least for those infants. Now, depending on culture, depending on whatever it is, later when the child is old enough to free themselves, right? Then that's a whole different conversation. There are some cultures that this is what they do, right? We have to honor that. But I think for the safety reasons, these are the recommendations. And, nobody will ever come to your house to force you to do things. But as long as you're aware of what those risks are, so that if you make that choice, you're making it from a place of understanding of what the risks are. I think that's what it is.
Yeah, I agree. I think some things just aren't worth the risk to me. I feel like that.
Yeah.
And I worry about my daughter too with the whole co-sleeping thing because, she does have an older sister that's 7. She's my stepdaughter. And she sleeps really hard. Like she sleeps, she's difficult to arouse, as you said, but they want to sleep together because, they're sisters. And so I strictly prohibit it because I think that she would not wake up if she was on top of my daughter. And Giselle, who's my daughter, she's only 2. What age do you think that kids can kind of be able to kind of have this sleepover or sleep with someone else? At what age do you typically see they're able to free themselves or wake up.
Yeah. No, when it talks about freeing themselves, unless you're like sleeping way over the child and completely, the way it is, the most critical period we're very concerned about is usually within those first 6 months, 6 to 12 months of life. After that, most times, the child who maybe is seeing that they're having a hard time breathing will move and they'll free themselves. But if you have a child who's still trying to figure out head control, they're still not fully able to turn their head to the side. Those kind of issues is when we really are very careful and want to pay close attention. But as they get older, again, over one, over two, most times, I think it's okay. Typical, of course, like you said, if you have somebody who's like occupying a large amount of space in the bed and they won't wake up if something happens to the child, then you really have to be cautious about. So it's not like there's like a hard rule that says, oh, yes, this is the age. But you kind of think about the developmental stage of the child, and then you can kind of use that to make a decision. Because there are older children who have other conditions that actually makes it hard for them to arouse if something happens. We have a very rare disorder called central hypoventilation syndrome, for instance, where these kids, even if their CO2 is climbing up because they can't breathe, their brain doesn't trigger them to wake up. But these kids might be older. So again, it all depends on the situation that you're faced with rather than so much of, oh, there's a 100% cutoff.
Yeah. You mentioned SIDS earlier, and that's something that I know I was like terrified of as like a first-time mom. What is, the most basic question, what is SIDS? And I know there's little information about how it happens or why it happens, but what can you share about SIDS?
Yeah, sudden infant death syndrome. And then they sometimes call it sudden unexplained infant death syndrome, essentially meaning that we don't fully get why. That we do know that there are certain risk factors. So co-sleeping, having a child, sleeping on their belly instead of on their backs, smoking, prematurity. There are few things that puts kids at risk. So when they've looked over the years and decreased those risks with the back to sleep campaign, with the, avoiding or limiting co-sleeping campaign, with, not smoking around children campaigns, those risks actually have gone down, but we still do have some incidences come up. And those ones, it may be sometimes a combination of still those factors, right? And then there are other times where we can't fully explain it. But this is why we say the ABCs of sleep really is important. ABCDs of sleep, we'll call it now. So your child should be sleeping alone. So that's the A, in a bassinet or crib on their backs. So alone on their backs in a crib or a bassinet. And then D is free of drugs. So you don't want anybody under the influence sleeping close to the child or smoking or things like that. So when you adhere to that, it drastically decreases the risk.
Yeah, that's so important. I wanted to talk a lot more about like different sleep disorders. And is sleep apnea considered a sleep disorder?
Yes, absolutely. It's one of the sleep disorders.
And is it sleep apnea one of the most common ones that you see in children?
Yeah, it is relatively common. So when we talk about sleep disorders, there are few things. For instance, you have behavioral sleep issues. So those are those like, the child that can't sleep, self-soothe, all of that. I would say that makes up close to 50% of sleep disorders. So that's a lot more common. Sleep apnea, depending on the research you're looking at, maybe as common as 77%. So not as common, but still, it's a serious condition. And then you have some other rarer ones, probably in older children, like circadian rhythm problems, like, narcolepsy and things like that. But sleep apnea, it is relatively common. I would say the 7% is probably a gross underestimation because it's probably much more common than that. But that's really what it looks like in terms of percentages.
And I wanted to talk about how this kind of relates to cleft. So I was looking online to see in our like cleft mom support groups just to see like how many people had concerns with, sleep disorders or sleep apnea. And to my surprise, there were so many people that were talking about it. And so I wanted to kind of ask you some of the questions that have just come up in the groups to see like to actually help us gain a little bit of understanding and what moms should look out for, particularly those that have children that were born with a cleft palate. And so someone asked, like, what are the signs of sleep apnea? What should you look out for in a baby? And I'm saying sleep apnea, but also, if you want to share, like, if there's other signs of other disorders that we should look out for as well.
Yeah, so sleep apnea is when you have pauses in your breathing during sleep. So if you think about it, you're going to sleep and your throat pretty much starts to narrow because the muscles around your neck are relaxed and your tongue might fall back. You might hear snoring. You might notice because the brain is very protective. So you might notice that the body is struggling to breathe. So what we call heavy breathing or increased work of breathing. Sometimes people will call it noisy breathing. Those are common things. You might see the actual apnea, which is they'll snore and then there's a pause and then they resume breathing again. You might see that. So if you have a child who has apnea, you need to really have them checked out. You may notice restless sleep. Again, this is a way for them to sort of almost like fight to keep breathing. So the body is just like trying so hard to breathe. So you may notice restless sleep. Some kids start to adopt a position of what we call neck hyperextension. So they're positioning their neck in such a way to open up their airway so that they can breathe better. And you may notice things like what we call bedwetting, so enuresis. So those kids sometimes have bedwetting, and usually, especially if you have a child who maybe was dry before and then they now started bedwetting again, I usually want to make sure they don't have sleep apnea. And then in the mornings or during the day, you may start to see, because if you imagine that all night long, their brains are just on guard, on alert, trying to protect them, they may have daytime issues. So daytime tiredness, they may feel tired or excessively hyperactive during the day, have a hard time focusing, they may be impulsive, kind of give you that almost like a child with ADHD vibe.
Some of the things that you have shared, actually, I've noticed in Giselle, and part of me kind of thinks like, okay, well, what does this mean? What interventions can I take, right, for her? And I want to talk a little bit about like what is the potential harm in that, right? Like if she is breathing, right? She's alive. So so she's breathing. So what are the like long-term effects of it not go like what if we don't do anything about it?
So there's quite a number of things that can happen when we have untreated sleep apnea. So, for instance, the first I would say is around, if you think about it, their brain is constantly waking them up to breathe. So, a child who has oxygen levels going down while they're sleeping because they have pauses in their breathing. Oxygen is important for brain growth and development, is important for the heart. It's important for hormone function and metabolism. And so the effects can be seen on all those areas. So we may notice just for their brain, first of all, we may notice things like excessive tiredness, daytime hyperactivity. We may notice they're irritable. Just kind of how we feel if you've had a bad night of sleep. You know how you just feel very cranky. You may feel like you're living in a fog. Our kids have the same thing. It may manifest differently. They may be more impulsive, and so they may be overtired. Um, and I've seen a lot of those kids. In fact, I've had kids that are diagnosed with ADHD that they come to see me in my practice, and we realize, oh wow, it may not have been ADHD. It may be poor sleep manifesting like ADHD, or it may be that maybe they do have ADHD, but because of the sleep apnea or any other sleep disorder, it's making their ADHD worse, and now they need multiple medications. So those kind of ADHD-like symptoms we'll see. In older children, we may notice that it may impact their metabolism. So we may notice that they have poor feeding, they may have, excessive weight gain, they may be really A combination of things, either eat excessively sugary, junk food, cravings. And so because of that, they gain weight excessively. They may be at risk for obesity. And then in younger children, we might actually see what we call failing to thrive, where they're not gaining weight appropriately. And the reason why, you can imagine, is all night long, they're trying to breathe. So that's increased metabolic needs. That's increased calories being burnt. And so they may lose weight. They may have a hard time gaining weight. So that's another thing. And then, just in terms of, growth overall, I've seen some children who have poor, like speech delays. They may have some learning delays. And sometimes it's really because their brain just has a hard time catching up because of all the breathing issues they have during sleep.
Wow. Can they grow out of it at all? Like, is this something that they can do, like, eventually, like, overcome by themselves?
There's been a little bit of research that showed that certain children who have very mild sleep apnea might outgrow it. So the issue, I think, is initial first 7 years of life, really, we talk about is a period of incredibly rapid brain growth and development. So will all those things, if we leave it to chance, are we potentially talking about a kid who could be an A plus student versus a kid who would be a C child? They'll thrive, they'll be okay, but are we potentially shortchanging them on some of those areas by weight? So I think there are a few things that would determine the severity. If you do a sleep study, this is why I always recommend getting a sleep study, because sometimes you see a child who's like having pauses in breathing and extremely agitated during sleep, and you do the sleep study and it shows, maybe really mild sleep apnea. Your approach may be a little bit different from a child who goes to sleep and they have oxygen levels going down severely, their apnea index is super high. You may want to be a little bit more aggressive in that kind of situation.
Yeah. And what does a sleep study look like? I've always been curious about this because I know myself, I'm a light sleeper. I've actually been asked if I have sleep apnea myself just because my own issues that I've had with just other issues that I've had. And I'm easy to wake. Like I wake up very easily. But I imagine having the sleep study would also like I wouldn't be able to sleep well. So I've always wondered how it's done. So just in the pediatric world, how would someone prepare for a sleep study and what can they expect?
Yeah, no. So that is so good. So a sleep study in the pediatric world usually entails the child coming into a sleep lab. So I usually will call it like a sleepover in a hotel, and you could come with your parent. So one parent goes with the child. There are different channels that are monitored, or different, I call them stickers for the child so they don't feel intimidated. So you have stickers on your head, and what that is doing, or what that does is it monitors the sleep stages your child is in. You have airflow channels, because remember we said sleep apnea, obstructive sleep apnea. We want to see, are you trying to take a breath and then there's a closure here, so you have an obstruction. So that's what that nasal cannula will do. And then you have like belts to see how much work of breathing are you doing as you're trying to breathe. Are you trying to breathe in, but your chest wall is not registering it because you have an apnea, right? And then we have different things like the pulse ox. We also have some stickers that are put on the legs to move. So see how much the child is moving, right? If you have a child who has restless sleep, we can actually measure how restless their sleep is based on all of these leads. So lots of stickers, nothing hurts. They just go to sleep. And yes, most parents are always concerned that, my child's not going to sleep. And they do it, and the child sleeps all night because they're in a different environment. And you always want to make sure that if you're going to have your child do a sleep study, that it is done in a place that is well versed in treating children who have sleep issues. So don't just go to any other lab. Make sure they have experience with pediatric sleep issues.
Yeah. I love that. It's making me, want to do that. Now, if you do find that the child has sleep apnea, what's the first approach to treatment?
So the first line, of course, you want to be seen by your child's either pediatrician or the ear, nose, and throat doctor. The most common reason why children have sleep apnea is that they have big tonsils, which is behind the throat, right? Which is structures in the back of the throat, and then big adenoids right behind the nose. So if you have any of those two things, the first step is really surgical removal. So you have to see the ear, nose, and throat doctor and you get evaluated. Now, I think there's a uniqueness with children who have cleft palate, if it's cleft lip or cleft palate, because you can imagine there's a space, right? And so we still will kind of take out those tonsils to create more room. But it gets very interesting because if you don't, and I've seen this a couple of times in my career, it's rare, but it's enough for me to say if you have a child who has cleft palate, you really want to pay attention to their breathing during sleep before they correct it. So I had a child who had surgical correction of a complete cleft, and they could not get her to breathe on her own when she was completed. Why? Because remember I told you the tonsils in the back of the throat? When you have cleft, everything is wide open all up there. It's all wide open and connected. Now they closed it all in. There was hardly any space for her to breathe. She started having a lot of snoring, a lot of gasping. So we had to take her to the OR to remove those tonsils, and she was a whole different child entirely. So with the anatomy in a child who has a cleft, it's a little bit different from the anatomy of a child who doesn't have a cleft. So this is really where you want to make sure when you go down this route, you have a whole team of people and that those people really know and have experience in taking care of children who have, clefts and things like that.
Yeah, I'm so glad that you brought that up. And I know I mentioned I was going to talk about the questions that people have been asking in the groups, I've been having my own questions. So I did have the ENT, when I spoke with them, they said they shared the same thing. You have to be really careful because while trying to correct one thing, you may inadvertently impact another area. And I know a lot of things that happen with children that are born with cleft palate is they can, if depending on the correction of the palate, they can still produce nasally speech depending on if the surgeon was able to create a good seal. Right. So having that air come through their nose when they're speaking. And I think the ENTs that I've spoken with as well is saying, like, you have to be really careful about removing the adenoids, weighing your options, because sometimes if you remove them, it can impact speech. And so there's a little bit of, I guess, gray area there that I think that, which I think that you are also sharing as well. Like you just have to be really careful about who's going to be doing this and if they're well versed in what they're doing specifically in sleep and also, cleft lip, cleft palate. So yeah, that's a really interesting thing that you brought up. Yeah.
Yeah. Yeah. I mean, the cleft lip, not as much of concern about that communication, but I think definitely for cleft palate, it's just really, it's not, I mean, like I said, these two patients I took care of needed those adenoids and tonsils taken out. They absolutely did. But this is where there was a good seal at the end of the day, things, hey, uh, but then really important to make sure that this is really thought through very well.
Yeah. I can read this one. Let's see. Has any one of your little ones been diagnosed with sleep apnea after palate repair? I'm curious to know. My little one was recently diagnosed with obstructive sleep apnea, and the sleep study doctor said that he has seen many cases of sleep apnea in kids after palate repair. My little has his soft palate repair at 8 months and is now 17 months, and sleep study specialists recommend tonsillectomy, and then ENT recommended adenoids and tonsillectomy. Any advice is welcome. So is that tonsillectomy what you're describing, the removal of the tonsils?
Yes, the removal of the tonsils. The adenoidectomy is the removal of the adenoids.
Gotcha.
Yeah.
So there's also mentions of the CPAP. I know that, I guess that would also be a form of treatment, right? Like to help moving forward. What does that look like?
Yeah. So surgery, that's the first step. Continuous positive airway pressure is really using a nasal or a mask to pump air to the back of the throat through a tubing that's connected to, I would call it a compressor. So if you remember, the airway is shutting down because the airway is maybe floppy or there's kind of some kind of obstruction. So what the CPAP is doing is helping to keep that airway nice and open, so that the brain doesn't have to keep you up at night, right? So really, it's an effective way of treating. But if you think about a child who's like 3 years old or 4 years old wearing CPAP, I think the question becomes, what's the end point, right? Like, what's the end point in that kind of situation? So this is something that one just has to be very mindful of. But it is effective. I would say I prefer addressing the root cause, because if you think about it, the CPAP is not necessarily addressing the root cause. It's just pushing air in the back of the throat. It is effective. So if you're stuck, you've done all the other things and it doesn't work, then yes, absolutely.
Do they grow back? Like, do the adenoids grow back? Just after those surgeries, what's the complications after that, if any?
Yes, this is a great question. There are some risk of the adenoids growing back, not that common. I think it all depends on when the child has the surgery. If the surgery is done very early in life, there might be a risk of the adenoids growing back because it hasn't reached its peak growth before you took it out. But if it was done like later, maybe like ages 3 and up, the likelihood of it growing back to the capacity where it obstructs the airway becomes less. So I think this is where it's important to follow up. So even when you've done the sleep study, it showed sleep apnea, you underwent surgical treatment, you want to make sure that you follow up with, another sleep study sometime down the line to make sure that this issue does not come back again.
Are there different levels of sleep studies? I feel like I've seen one that was more maybe like 2 nights or something like that, like kind of like different stages. Is that something that exists?
Yes, yes. Now, for adults, actually, the mainstay is what we call a home sleep test. So it's from the comfort of your own home. You just wear it. It's not as comprehensive as an in-lab sleep test, but it is extremely, extremely effective. Now, for children, though, some places, like in my practice, we do home sleep tests, but it doesn't give some other additional information. So if I wanted to see like your EEG, or I wanted to see, oh, do you have restless leg syndrome? I may not have that answer. But if there's a high risk and I'm just concerned, is there sleep apnea or not? It tends to be just fine. It tends to work. So definitely something to consider. The issue, though, is with most insurances do not cover the home sleep test in children. They cover it in adults. So that may be something you may need to pay out of pocket or something of that. I mean, I think the goal is to get you an answer. Does my child need surgery or not? Does my child have sleep apnea or not? It can provide that answer. But I would just not recommend that this is done by anybody. You really want to make sure you're doing this testing with someone who has expertise in it.
Yeah. I see a lot of people in the groups just really talking about particularly PRS, which is PR band sequence. That's something that I'm seeing most common that people are talking about, that they needed a sleep study. And, sometimes some children require a jaw distraction. Have you seen children in your office that have PRS potentially? I know it's a little rare.
Yeah, this is definitely something I've seen throughout my practice. Most times these kids are diagnosed very early. So they may present in the hospital where every time they try to go to sleep, especially laying on their back, they start having obstruction. So many times that's how we tend to see them. And then they come into the hospital, they get a sleep study, and really we have a hard time getting them to breathe on their own. And so sometimes jaw distraction. We also have what we call tongue lip adhesion, where they kind of suture the tongue to the lip so that the tongue doesn't fall back, because that's really the mechanism. The tongue is falling back and obstructing the airway, and that's what's causing all these issues. So we work very, very closely with our maxillofacial team. So they're the ones that really do a lot of this. Sometimes plastics will do it and things like that. But it's something that really can be very problematic, definitely more dramatic.
Do you think that people should do their cleft treatment first and then their sleep treatments, or is it the sleep treatment first and then cleft care?
It depends on what's going on. Every child is so different. So if you have a child who has PRS and they have severe sleep apnea, you're not, I mean, this is newborn period. They won't be even old enough for a cleft repair by the time you need to do something about it. So I think it all depends on what stage they're in, how old they are, and then what risk factors, where the obstruction is taking place, how bad is their cleft. All those things will play a role in the decision you make about it.
Yeah, that's so true. And just like a little bit about your practice that you've talked about, you're the founder of the Restful Sleep Place. Talk to me a little bit more about your work there.
Sure. So I was in academic medicine for a while. And then after about 10 years, I went ahead and started my practice. And it's a, holistic private practice where we provide personalized, really highly personalized care. So you could see like a lot of the questions you were asking me, I keep saying, it depends. It depends. So it's really about tailoring needs to specific patient needs so that you don't feel like you get this generic recommendation. And so really that's our focus, is really finding out what the patient needs are, what the family's needs are, what the family's goals are, and creating a plan right from the minute they walk out into our office all the way to the very end of that journey, to make sure that they understand what the options are. And sometimes, that may look like helping folks understand what their rights are, and what, how they can advocate for their child, to really helping them navigate, oh my goodness, there are 3 or 4 options on the table now. How do I make the best decision? So we provide all that care, medical sleep issues, as well as behavioral sleep issues.
Oh, that's phenomenal. And where are you all based out of, and how can people sort of reach you do you offer consults? Like this podcast is pretty global. So what are ways for our audience to reach out to you and
Yeah. So we provide services to people, medical service, specific services to people in California, in New Jersey, as well as Pennsylvania. I'm actually based in Pennsylvania. So we see patients remotely, we see them in person. I do offer, because again, there are not very many pediatric sleep specialists. So we offer like consultations and coaching for families who are based in other states. For instance, you have all these issues and you're like, I don't know exactly where to go, how to navigate it, or is this true? And so really then in that case, no matter what state you are, I may not be able to directly treat your child, but then I can help you kind of interpret what it's looking like, provide an opinion, and then help you kind of navigate what you need to do to make sure you get the care your child needs.
Yeah, I love that. I love that. I just want to thank you so much for coming on. I think that this is certainly something that is a concern to a lot of cleft moms. I know there's so many questions about sleep apnea and just having like sleep studies. I used to hear that so much, that, it's been recommended that they have sleep studies, and so just getting like some insight into what that looks like for families is so helpful. So I appreciate you coming on with us today and sharing the information.
Yeah, no, thank you so much for having me. I really do appreciate it.
Thank you all for listening to the Our Forever Smiles Cleft Mom Diaries and Support podcast. Be sure to subscribe and submit a review of the podcast wherever you listen. I hope that you've enjoyed this audio experience. Maybe you cried a little, laughed a little, but more importantly, I hope that you feel a little piece of reassurance and even joy in your journey. Talk to you next week. Hey everyone, it's Laura here. I'm popping in today because I need your help. If Our Forever Smiles has ever helped you, if you've learned something new, felt less alone, or found hope through this podcast, then I'm asking you to help keep it going. Creating this podcast, sharing stories, and building a space where cleft families feel seen and supported is something that I pour my heart into. But the truth is, I cannot do it alone. If we want to reach more families and provide even more resources, we need your support. So I thought of a creative way to do this. For just $2 a month, you can help ensure this podcast keeps going strong. For $5 a month, you'll unlock exclusive Moms in Real Life content, real unfiltered conversations about motherhood and career and everything in between. And then for $10 a month, you can get everything plus exclusive merch to show your support. If this podcast has helped you and you want to see it grow to help other families that are probably facing the very same challenges that you are facing right now, please consider supporting us today. Every dollar goes toward making a difference for cleft families just like yours. And right now we'll be using the funds to elevate the show for production. So we'll be able to add more video and just get new equipment. And as soon as this community is established and we're able to do more, we definitely plan to go beyond the scope of just this community. We want to be able to support scholarships for new craniofacial surgeons. We want to be able to support global surgeries and just really spread our efforts to continue to make an impact in our community. I just want to thank you in advance, and I'm just so grateful that you all are able to support me and support this community here. And it's definitely something that I'm really looking forward to. The link is in the show notes, and I just want to do a shameless plug here. The Moms in Real Life podcast is so cool, so candid, and yeah, it's definitely something that you'll want to check out. Thank you all again.